the most important magic and wonderfulness of this meeting is that I get to see my colleagues year after year. And of particular pleasure to me is when I get to invite somebody that I have a lot of affection and respect for. And because his bio was very brief, I just want to say a few words. Dr. Mark Schluter, who was the chair of ophthalmology at University of New Mexico in Albuquerque, my alma mater. We were both medical students in 1980. I, as a nerd, sat in the front row. He, as this cool guy, sat in the back row, I thought sleeping. I was probably one of the older students. He was probably one of the youngest. And we took different paths, but we stayed in touch. And he has very graciously agreed to speak with us. Let me just say that he also is a musician, and that's how I met him, really. I never saw him in the back row, and he was sleeping. I didn't want to wake him up. And we had a music party at my house, so he's also a wonderful avocational musician, and I think most of us who love music know musicians have a lot of soul. Anyway, Dr. Schluter is a native of New Mexico and attended medical school in Albuquerque, and he did his ophthalmology residency at the University of Virginia, and then returned to the sunny skies and wonderful Chile of New Mexico, where he joined the faculty of UNM in 1991 as its first ophthalmology chief. In that position, he helped to grow the eye service that is now nationally recognized Center for Ophthalmology Residence in Education and Eye Research. In 2004, he and his wife, Sonia, then began a practice in beautiful Sonoma, California, and he now splits his time between New Mexico and California, working in both locations. He goes back about a month a week, and I'm very pleased to see he's still the medical director of the New Mexico Commission for the Blind, Emergency Eye Care, and Vocational Rehabilitation Programs. And now he's going to talk about a poke in the eye. So, Dr. Schluter.
Thank you, Rhonda, for those kind words. That band we were in wasn't nearly that good. But let's go ahead and wake this up. Thank you very much for having me. I thank Dr. Lair, Heather Hylison, and Beth for facilitating my coming to you and speaking on ophthalmology. I know the theme of this general conference is emergencies, and if I can find, fortunately there's very few real ophthalmic emergencies. I could be out of here in about 5 minutes if that's all we covered. So I want to expand the spectrum to include emergencies, urgent situations, and urgent situations for bigger populations. The U.S. population and some of our demographics has some interesting correlations to this, as well as some of the issues that come up basically end up figuring out if something is an emergency or an urgent situation with primary care or emergency-based physicians. So little of medical school includes eye or vision clinical experience. It's a tough thing to examine, and people are generally very intimidated when faced with much in the way of an eye problem. So I want to pull from a lot of different clinical topics in this talk, and I'm going to also emulate Dr. Lair, who can talk fast. I've got a little more than an hour of material here. We may cut it a little bit short and cover some of the other topics if you want after hours. So I'm prepared to give you all you could want or need in the eye department here. I have no commercial or financial interest in any of this subject material. We will be discussing a little bit about off-label uses of certain drugs and devices. Today's presentation boils down like this. I want to briefly cover you'd think an eye doctor could use can everybody hear me okay? Is that okay? Brief coverage of anatomy and physiology, which should be a review. Talk a little bit about a screening eye exam. I'm not going to teach you how to do an eye exam or beat all those points to death. And then jump right into clinical issues, starting with red eye, things related to the red eye, ocular trauma, flashes and floaters, sudden visual loss, and then, time permitting, eye diseases infecting large populations, our number 1, 2, and 3 public enemies in vision: diabetes, glaucoma, and macular degeneration. So here we go. Clinically, anatomically wise, in eye care, we divide the eye into a front part and a back part. The anterior chamber bounded by the cornea. Anterior chamber contains aqueous humor, which chemically looks like lactated ringers with vitamin C added. The back of the anterior chamber for us is the lens, which sits in back of the pupil. The major element of the eye, volume-wise, is the vitreous cavity full of vitreous gel, which looks like a clear liquid, but is actually a living tissue with a high water content. The wall of the eye has 3 layers, sclera on the outside, which is rather tough, avascular, and as its collagen fibers become very regularly arranged, it becomes clear, and that's what your cornea is. Middle layer of the eye, something we try not to interact with, is called the uvea, also known as the choroid, has 10 times the blood flow per gram as something like kidney or brain. It's really wild stuff, and it's rather hidden from our view looking at the retina because it's underneath the retina, but its major function in life is to nourish and give the retina oxygen and take away waste products, not so much those retinal vessels that you see with your ophthalmoscope. Of course, the inner layer of the eye, the retina, 1/4 of a millimeter thick neural tissue with no inherent connective strength, and it's actually sucked onto the back of the eye by vacuum. There's a fluid pump in the outer retinal layers that keeps this space dehydrated, keeping your retina attached to the back of the eye basically by suction. Again, aqueous humor manufactured by active secretion from the ciliary body. Its function of aqueous humor is to nourish the lens and the cornea. It flows through your pupil and out through the trabecular meshwork out here in the angle of the eye and the venous circulation. A quick review of histology. Here's your cornea, the outside world being here, corneal epithelium. This is what you scratch off when you have a corneal abrasion. It has a basement membrane called Bowman's layer. That's what fluorescein dye stains. Much of the cornea is called stroma, a relatively acellular, heavily collagen-containing matrix, and a single layer of endothelium on the inside which pumps water out of the cornea, keeping the cornea dry. That helps it remain clear. These cells don't grow back, by the way, so if they're injured by trauma or cataract surgery or what have you, your cornea can fail and swell up, and that requires transplantation. Histology of the retina, and in this case we're having light coming from your left to your right. It goes through all these cell layers. The very end of the retina is the rods and cones. The rods and cones function in a very highly oxidative environment. Here's the choroid for you. Look at the size of that blood vessel. And that's the choroid is what's really taking care of your rods and cones, and the very small cell layer between the two called the retinal pigment epithelium. These are the janitors and the housekeepers. Every night when you sleep, you slough off your photoreceptor outer segments, high lipid containing cell membranes which get processed by the retinal pigment epithelium, taken out of the choroid. A lot of metabolism and interest going on here, particularly with our aging population. Now, wouldn't it be nice if everyone could see a retina like this? There's a widespread new technology in eye care called optical coherence tomography. I guess the GI people use this too with endoscopes, but we can basically in real time with an office-based machine, costs about $50,000, but get very high quality, high resolution pictures through not only the inner retina, but all the cell layers, including the rods and cones and the retinal pigment epithelium. And I'm going to be showing you some of these OCT images with selected diseases. So I wanted to show you a normal one. Here's the foveal pit, for example, and all the retinal cell layers. So this has really helped ophthalmology in their imaging and their understanding of retinal diseases. Here's a good color photograph of a retina in the right eye, and I want to just briefly review the path that axons take. Here's the right eye, fovea is right here. That's where you see 20/20. Axons from this part of the retina take a completely different route to the optic nerve, above versus below. No axons go right through the fovea. That's one reason it can resolve high spatial resolution with vision. So the way the eye and the retina are wired up is basically an up-down phenomenon. Problems in the eye, on the optic nerve, with blood vessels or nerve as well, tends to cause visual loss that tends to be above or below or both. But I wanted to, again, touch on the topography of the eye and the way the signals reach the optic nerve. 1.5 million axons all turning and leaving the eye. That's what the optic nerve is. You can actually appreciate the axon's texture here. They're the very most superficial part of the retina, and they look like corn silk. You can see that on this slide, and some of you have seen it with your direct ophthalmoscope. The texture of the retina just off the vertical poles of the optic nerve. You can see a lot of those axons, and we can image them with technology, but there they are. Here's all you need to know about optics. They taught us in medical school. They made this so hard to remember. The image is focused in front of the retina and back of the retina. Hooey, what really happens is when you're nearsighted, your eye is too big. When you're farsighted, the eye is physically small. That's the underpinnings of refractive error tends to be with the axial length of the eye. So we start triaging people, looking at them in the waiting room based on what kind of glasses they're wearing. These are the folks that may, for example, get retinal thinning, retinal stretching, retinal detachments and holds, vitreous problems with vitreous condensation. Farsighted little eyes might get angle closure glaucoma because they're crowded inside. So we'll triage in terms of risk assessment and triage just simply based on refractive error, because that does correlate with the development of some optic problems. A complete eye exam in eye care only has 8 parts. Here they are. I don't want to beat these to death. For purposes of emergency and urgent situations, I want to boil that down to what we might call a screening eye exam. Battery in my pointer's dying. A screening eye exam is in any eye problem. Visual acuity, that's our number 1 vital sign of the eye. That's like a blood pressure or a heart rate. For us, it's visual acuity. I want to talk a little bit about doing a pupil exam. And basically, pen light exam. You can do a lot with a pen light. And for example, faced with a pink eye or a contact lens-related eye infection, you're not going to need to do visual fields. That would maybe apply to something else. So all parts of a complete eye exam aren't going to be mentioned with some of the clinical entities that I'm talking about. But I want to refresh your memory in terms of taking the vital signs of the eye, a screening eye exam. Visual acuity, the subjective complaint of blurry is not enough. We start with a wall chart. We only care about what the best corrected visual acuity is. If someone's been in an accident, assaulted, their glasses are gone, they can't read an eye chart, we can always use the near card. That's useful with nearsighted folks. I'm just going to skip this pointer. Counting fingers if they can't see an eye chart. How many feet away can they resolve 1 to 3 fingers? They can't see that. Do they see hand motions? Up and down, grossly, movement. Can they see light? Is the sense of direction intact or not intact? And the lack of all vision we call no light perception. So if someone has an eye problem, they can't see the eye chart, we can still get some idea of their visual function in an emergency or urgent situation. So there's your eye chart, and we have them read down as far as they can until they miss half or more letters on the line. Okay. Near cards, pretty self-explanatory there. Most people who wear glasses are nearsighted. Their ideal focal point is in the reading range, and so you can do a lot of acuity testing with a near card. Pupil exam, P-E-R-R-L-A. I want to really kind of not shoot that down today, but show you how incomplete that is in taking vital signs of the eye. First off, with pupils, a couple of pearls. Monocular visual loss doesn't give you a pupillary abnormality. It doesn't give you a blown pupil. You could cut your optic nerve, but your pupil will still be the same size, at least at rest. If the light reaction is intact, you don't need to check accommodative response. There is no clinical lesion that can leave your light reaction intact, but take out pupillary constriction with accommodation. With a pupil exam, in eye care, we note the size of the pupils in a dark environment, the presence of a light reaction, and then we do this thing called the swinging light test, the swinging flashlight test. Anyone ever hear about that? It's a dynamic exam. I've got a little video of it. What we're looking for is something called an afferent pupil defect. Remember that picture of the retina and the optic nerve. 1.5 million axons in there, all going to the brain, afferent. You can take out half of those axons and still maybe see 20/20. Depends on what axons you've taken out. You can take out half those axons and your pupil will still react to a light, and it'll be equal to the other eye. So you can have significant disease in one eye or one optic nerve and still meet the criteria for PERRLA. Let me show you a swinging flashlight test. What we're going to do with this, we're going to have a patient look at something off in the distance in a dim room. These are kind of hard to video. We're going to use a bright light, and we're going to move that light from one eye back to the other, back and forth. What we're looking for is an initial dilation when the light moves from the so-called good eye to the eye with a problem. If we see this initial dilation, and you'll see it in the movie, that's an abnormal finding. It always means trouble, and it's the only objective way to check the afferent system. Visual acuity requires a cooperative patient who's communicative, telling you the truth. So do confrontation visual fields. But our pupil exam and the swinging light test takes patient cooperation and even mental status out of the equation. And when it's abnormal, it always means trouble. It will always get an eye care provider's attention. First off, I want to show you a bad one. This is a marked afferent pupil. Come on back up here. Well, every computer does video differently. Let's see if we can. Here we go, I think. Is that going to play? Let me go to the next one. Here we go. So light coming in from the right, that pupil just reacted. Light coming in from the left, that pupil just reacted, P-E-R-R-L-A. But as we swing back and forth, the right eye's got to, see that dilate? Back to the left, that's the normal eye. It's going to run again. Pupil reacts. There, did you see it? Other pupil reacts. Swing back to the right eye, and it dilates as its initial finding. He's got a big scar in that right retina and optic nerve. So he's got a right afferent pupillary defect. The other name for that was taught as the Marcus Gunn pupil. They mean the same thing. Let me just loop that one more time. Here we go. Pupil responds to light. Other pupil also responds to light. But back to the right, dilation. And if you were watching the left pupil, since they moved together, they would both dilate right there. The point is, his Ettinger-Westphal nucleus sees less brightness when the light swings from the left eye to the right eye. And so it lets both pupils open up a little bit initially. But if you're just looking for pupil reaction equal to light and accommodation, doesn't mean a swinging light test and an opportunity to pick up a key vital sign of the eye was lost. Visual fields, not going to beat this to death. Visual field defects to confrontation only come in 3 basic flavors. If you've got something wrong in your eye or your optic nerve, remember that's basically an up-down orientation. Causes upper or lower field loss. Moving back in the visual system, our next structure is the chiasm. Problems in the chiasm do something to affect bitemporal fields, which may be incomplete or partial. It's not necessarily all black on the bitemporal sides, but defects will respect that vertical midline through fixation. And finally, as you move back from the chiasm, everything in back of that causes a homonymous pattern loss that's on the contralateral side. Again, it may be incomplete or partial, but the defect will respect that vertical midline. The remainder of our exam steps I want to sort of present in a problem or clinically based format. And to summarize this section, I want to, this is pretty important. When you're faced with an eye problem, just like with every other thing in medicine, the history of the illness, systems review, and a tailored physical exam are the key. Avoid the emphasis or the anxiety that going right to the fundus exam causes. A lot of the things we're going to talk about don't even involve the fundus exam. Get the vital signs of the eye and the other elements of the onset, the progression of the problem, and associated findings from head to toe. Those things won't let you down. So let's go into the red eye. And this is, I'm not going to include trauma in this quite yet. Non-traumatic red eye, we all saw this in medical school when you're a broad differential of conjunctivitis, also known as pink eye, iritis, uveitis, similar terms meaning inflammation of something in the choroid or the uveal tract. Corneal inflammation will give you a red eye, corneal ulcers, herpes infections, and the like. And finally, this entity, acute glaucoma, which is, when you think of glaucoma and the glaucoma that's out there in this country, it is not acute glaucoma. This is a rare bird. This is sort of a red herring. We almost shouldn't see it anymore, and I'll show you why, but it belongs in the differential of the red eye. The common form of glaucoma has no symptoms at all, which makes it so much more scary and an urgent public health problem. Pearl number one, when you're faced with a red eye, uncomfortable eye, acute, chronic, doesn't matter, as part of your exam step, pay particular attention to the eyelid margin where the lashes come out of the skin. A very common issue in eye care we call blepharitis, and it's basically a skin problem that makes the eye red. It comes in two forms, a form of sort of abnormal exfoliation, if you will, of the keratin-containing cells at the eyelid margin with buildup of keratin, dried sebaceous oils, skin byproducts, and an overgrowth of staph epi on this site that then falls into the eye and triggers the eye's immune reaction. So it looks like this chronic mild pink eye. It's usually worse in the morning. It goes away briefly with antibiotic drops, but it comes back. That's one form of blepharitis along the eyelid margin. If you see any crusting, any white stuff building up there, any yellow stuff, here's another picture of it with seborrheic accumulation along the eyelashes, and this person has backed up meibomian glands as well, all these little white things here. It's where they've got lipid backed up into the margin of the eyelid. These are supposed to help your tears wet the eye, but for some reason this is very prone to malfunction and functioning poorly in humans, causes what's always misinterpreted as dry eye, severe allergies, pink eye that won't go away. So and it won't affect the vital signs of the eye. Blepharitis never knocks down your visual acuity off the chart or gives you a pupil abnormality or something in the orbit. Its physical findings are confined to the eyelid with crusting, scaling, debris buildup, and a red eye that's often worse in the mornings and tolerates wind and cold air poorly as well. Main treatment for this, hot compresses and lid scrubs, local care, local decontamination. Doesn't require prescription therapy right away. In eye care, we'll also put people on omega-3 fish oil or flax oil, try to get them to stop smoking, other things just to improve their internal chemistry to cause less eyelid problems and eyelid malfunction, leading to a good environment for staph epi to grow in. Another variant of eyelid problems is when one of those meibomian glands ruptures within the skin. That's what a chalazion or a stye is. Here's one in the upper lid. Here's one in the lower lid. Once they've ruptured and caused this, the cat's out of the bag. We can numb it up and lance it, but the problem really was this chronic blepharitis all along. And we try to treat these conservatively with hot compresses and lid scrubs as well. These things are almost never infected, although they look like an abscess. They're a tender, red ball, but it's all a sterile reaction to the lipid that's been released into the skin from a ruptured meibomian gland. On to viral conjunctivitis, a true infectious pink eye. The conjunctiva is the same histology as the oropharynx. It's involved in the same kind of process, and you're better at weeding out pink eye than you think if you evaluate sore throats. And most sore throats are viral, right? Most pink eye is also viral, tends to be bilateral. The second eye, for some reason, will often have a milder course. You'll frequently find an associated upper respiratory tract infection because there's a lot of crossover here. Key signs, conjunctival injection, edema, swelling, and a watery discharge. The surface of the eye, lymphatics drain to preauricular lymph nodes, and those may become enlarged. And certain forms of viral conjunctivitis, not all of them, but certain forms can be highly contagious, mainly adenovirus and echovirus. These people can start one whopping epidemic in your waiting room. So if someone comes in with clear viral conjunctivitis, something looking like this or worse, you might want to take them on back. Don't let them sit down. Don't let them wipe their tears all over your chairs, because they can leave a little gift for 10 more people and a chain letter ensues. There is no specific treatment for viral conjunctivitis. It never damages vision, never causes long-term sequelae. Treatment is supportive with decongestants, antihistamines, cold compresses. Sometimes in eye care, since we have a slit lamp, We know they don't have herpes. We can give them steroids and artificially suppress their misery, but viral conjunctivitis runs its course like the common cold. Bacterial conjunctivitis, URI is a little less common with these. Again, it may affect one or both eyes. You may have a node, conjunctival injection like before, swelling, more of a mucopurulent discharge and lid crusting. There you have your bacterial conjunctivitis. Looks like just bacterial pharyngitis and this is a severe case, an exudative discharge. These we do treat usually with we have a lot of fluoroquinolone antibiotics in eye drop form. Any of them work just fine for this. So does bacitracin, erythromycin, all those things. One nice thing about ophthalmology, we can get drugs in such high levels there locally that even things which are partly resistant, they work okay for us. Here's another good example, a little kid with, this is more than just that blepharitis, keratin crusting. He's got this yellow exudate discharge, a red swollen eye, but still bacterial conjunctivitis is not going to knock down your vital signs of the eye. They'll be able to read the chart, their pupil will be normal, their motility will be normal. You won't have orbital or deep findings or other things which lead you astray. So here's your first mystery case in your urgent care center. In comes a 45-year-old lady with 3 days of eye pain, scratchiness, light sensitivity. She's not a contact lens wearer. Her acuity's okay. She's 20/40. Got this viral-looking conjunctivitis. Anything else? Remember, with pink eye, we look carefully at eyelids and lashes and the lid margin. Phew, what's that? This is your first attack of ocular herpes simplex, a skin lesion with a viral conjunctivitis. There's no garden variety pink eye that should affect your skin. And so she's got 2 or 3 big ulcerated fever blisters here, and she's going to get treated with topical and maybe systemic antivirals. Here's a more typical presentation of primary ocular herpes simplex, multiple skin lesions in a preteen or an adolescent with a mild conjunctivitis. It's the recurrent herpes when it comes back. It's when it comes back in your cornea. And here's a corneal dendrite, staining with fluorescein under the slit lamp, a small one, a big one. These patients aren't too hard to figure out because they'll tell you they've had herpes before. This hurts like stink, and it'll knock down the visual acuity and other vital signs of the eye. And so these people are fairly easy to detect. All you have to do is listen to them and check the vitals. On a closely related topic, here's our friend zoster. Did you know that nearly 1/3 of all cases of shingles are in V1, and that may affect the eye? How do we know if the eye's in trouble? Send them to the ophthalmologist, right? No, vital signs, visual acuity, pupils, motility, basic pen light exam. If all that checks out, you haven't got shingles eating up your retina or your orbit. When shingles is causing someone trouble, it's going to knock down something on that screening eye exam. And hopefully we're going to see less and less and less of this. We still treat it with oral antiviral agents, but now that the vaccine is here, we're not seeing as many shingles. At least I guess it's only people over 65 can have the vaccine, right? It's 60 now. I've seen a few 55-year-olds with it, but hopefully our friend shingles will be less and less common. But again, the vital signs of the eye, basic visual function, appearance, and pupil exam won't lead you astray with that. You're back in your urgent care center. Here comes someone with a red eye. Oh, they wear contact lenses. Been getting worse for 3 days. They took their lenses out, still getting worse. Visual acuity. They're blurry on the chart. They can see 20/60, but they need their lenses. Pupils okay. On this photograph, this thing here is a reflection from the flash bulb in the slit lamp. This is a white spot on the cornea. Well, pink eye won't get you that. That's your earliest corneal ulcer. A bunch of white blood cells which have crawled through the cornea from the limbus and are fighting off what's presumed to be a bacterial infection there. Here's a larger corneal ulcer. This one's off near the limbus. I think this was from accident at work and corneal contamination. The chance of an epithelial abrasion becoming something like this is less than 1 in 1,000. Epithelial abrasions don't turn into corneal ulcers, but contact lens patients, people that have had trauma at work with vegetable or plant matter, and people lying comatose in the ICU who are in a high toxic environment, lots of bad bugs, brain impairment of their blink reflex, or fifth nerve palsy, you got to watch out for that. Here's a pseudomonas corneal ulcer going all the way across the cornea. It's going to be 24 hours before it busts through the thing, the fluid of the eye leaks out, bugs get in, and we know how that's going to end. So this is why people in the ICU get lacrolube or erythromycin. We want to really keep the eye moist and check it daily for anything white in the cornea. Back to your urgent care center, another red painful eye, 35-year-old healthy person, really complaining of a lot of pain, watery discharge, no other illness, light sensitivity, vital signs of the eye, visual acuity is okay on the chart. Their pupil's a little smaller than the other eye. They don't like you shining light in there either. You shine that light in there, they back away. You start looking at the eye, you touch it, press on it a little bit. With pink eye, this won't hurt. With iritis or uveitis, acute iritis, it will. They'll jump out of the chair. So here's your case of uveitis. And I want to show you this is what we have fun with the slit lamp looking at uveitis. Here's a magnified picture of an anterior chamber. Here's the cornea. Slit beams going through the anterior chamber. Here's the iris in back. So in between here's aqueous humor. And you see all that fog? The aqueous humor is full of plasma proteins and white cells. The blood aqueous barrier is inflamed, it's leaking, it's broken down. They've got inflammatory disease inside their eye. Why? It's usually idiopathic. It's a form of an autoimmune condition. This is our rheumatology of the eye, all wrapped into iritis. Here's another slit lamp picture. Cornea on your right, iris on the back. All these little white chunks on the cornea of white cells floating around in the eye. They stick to the cornea. They hold hands, so we can see evidence of that. Here's a wide-angle view of ocular inflammatory disease with synechia or adhesions between the iris and the lens, corneal inflammatory precipitates, iris neovascularization, all kinds of things going on from a chronic case of uveitis. And, of course, uveitis in some forms, when it's associated with a systemic disease, can spill over into the back of the eye. Here's sarcoid with an inflammatory granuloma in the choroid, inflammatory granuloma infiltrating the optic nerve. There's a case of rheumatoid arthritis and active rheumatoid vasculitis in a retinal vessel. So you might see something like that with rheumatoid and lupus. So this topic of iritis gets real messy in a hurry. A wide spectrum of problems from the front of the eye to the back of the eye, might be acute, might be chronic. We're talking about the red eye, though, in this lecture, the people that would walk into your emergency room or clinic with the acute anterior iritis. What do we think of those? Over half of them are HLA-B27 positive. And as physicians then, you can tailor some of your systems review and further questioning, looking for B27 associations with these 4 diseases that are also linked to it. Something else that might come up is when an eye care provider calls you and says, I got this guy with uveitis, I need you to work him up, doc. Find out what are we looking for. The list is incredibly long for that. You want to avoid a shotgun approach. Eye care people will call you when we see stuff in the back of the eye. The link with posterior uveitis and systemic disease goes way up. Or when they have uveitis in both eyes. Any uveitis we're taking care of that's behaving atypically. It's not responding to low-dose topical steroids and the usual things. We're following an atypical course. We're going to look for a systemic cause with that. Eye care people are also very timid by nature. We really worry about giving people prednisone and other immune suppressive drugs. We'll call for help on that. But there's got to be communication back and forth. If someone sends you a uveitis patient for a workup, you want to know what's on the eye care provider's mind, the top 3 things on the differential. Do not do a shotgun workup, a shotgun approach. It's non-productive, it's expensive, and it'll cause you more confusion than it will solve. Another related topic, when should you get an eye exam on someone you know or suspect has autoimmune disease? Juvenile rheumatoid arthritis, especially the polyarticular form, the form that affects few joints. They can get a chronic smoldering uveitis with very little pain, but glaucoma. It slowly blinds them and can be relatively asymptomatic. JRA people should have an eye exam. when you know or suspect giant cell arteritis. For some reason, this is sort of an orphan condition that no one claims responsibility for. In ophthalmology, we at least have the ability to examine blood vessels directly in the body. We can look for that. And ophthalmologists in many places are the ones doing temporal artery biopsies. And so ophthalmologists might be able to help you in figuring out giant cell in terms of risk assessment, or if it comes down to doing a biopsy. Patients with known or suspected sarcoidosis, they can have a lot of eye findings that may be asymptomatic. We can also find things in the eye which can be diagnostic of sarcoid and might save them, a lymph node biopsy in their mediastinum or an invasive procedure. And of course, anyone with autoimmune disease that's got eye problems should be seen. And as a final note, when starting people on hydroxychloroquine or Plaquenil, they should have a baseline exam then. Why? We're looking for fundus changes which might come up and be unknown in terms of their onset later on. So they get a baseline exam, and then you don't have to worry with Plaquenil or hydroxychloroquine until about 3 to 3.5 years of twice-a-day therapy. That's when you reach a threshold dose when maybe, just maybe, macular pigment changes will start. If these are missed and allowed to progress, they can permanently harm central vision. So we want to check them when they initiate therapy, and then it's usually annually till about 3.5 years. If they're taking it BID, then they're going to be checked every 6 months. Next red eye, next mystery case. 80-year-old lady comes to your ER, brought by her family, not doing real well, a lot of pain. She's throwing up, she's got a headache. They wonder if she's got an aneurysm. Screening eye exam. Acuity in the right eye way down. She can't see the chart. Pupil exam, messed up. Right pupil's bigger than the left and non-reactive. Further thoughts? Acute glaucoma. There's acute glaucoma. It's dramatic in it's rare, but it's dramatic in its presentation. Here's one of those eyes close up with that mid-dilated non-reactive pupil. Intraocular pressure is so high that the cornea has edema in it, making it look hazy or steamy. That's not an out-of-focus photograph. The vital signs of the eye took a big hit. So here we have a severe pain along with a headache, severe acuity loss, pupillary abnormality, markedly elevated intraocular pressure. You don't need a fancy machine to measure it. It feels as firm as this table. The hazy cornea, the autonomic sign. This is rare. Again, what happens is in a small crowded eye, there's resistance to flow of aqueous through the pupil, pushing the iris forward. And as the iris, if it bows forward far enough, it can suddenly close your trabecular meshwork, leaving aqueous no place to go. It's still manufactured by active secretion. Intraocular pressure comes up to equal your diastolic blood pressure. And you can imagine the implications for optic nerve circulation after a few hours of that. Every eye care provider is trained to spot these people at risk who have the small eyes and a shallow anterior chamber. Remember how deep those iritis patients were? Look at this. Iris is bowed way forward. This isn't attack. This is someone at risk. When we find those, we will, if they're bad enough, we'll use a laser and drill a little hole in the peripheral iris to not allow it to bow forward anymore. We've equalized the pressure on both sides. It's the only form of glaucoma we actually have a cure for. And so that should be a non-entity out there. But there still are people. They're always elderly. They've still got their cataracts in there. They usually wear glasses that magnify things. They're hyperopes. It's telling you they have a small eye. And finally, you'll see on a lot of medicines, don't take this if you've got ABCD, glaucoma, causes a lot of confusion. What they're really saying is things with an anticholinergic or an adrenergic side effect will dilate your pupil, and it's that dilated position that maximizes resistance to flow in people who are susceptible. So this can trigger an attack if someone's super susceptible, but if they've got the chronic simple form of glaucoma they're taking drops for, they're under treatment, this warning does not apply. Those patients can use these drugs and use them well. They won't have problems with that. Here's another red eye entity that crops up. Someone gets up in the morning, goes to the bathroom, brushes their teeth, looks in the mirror, and screams because their eye is bleeding. And then it starts hurting. It starts hurting after they noticed the giant red spot. There was one of the prisoner. I'd like to see if he still has a cornea. If you call this patient in, their visual acuity fine. Pupils, fine. Everything else is fine. Isolated subconjunctival hemorrhage, sort of a normal variant. It's always harmless. It has no correlation with systemic or ocular disease. Might be recurrent. And you can actually triage these on the phone. They don't need anything special done with this big red spot on the white of the eye. Drops to get the red out aren't going to work for them. It's going to take a few weeks for the hemoglobin to go away, and they look ugly. And finally, as a miscellaneous topic, orbital and preseptal cellulitis, an infectious process in the skin, eyelid. Is it in the orbit or not? Well, how do you find out? Basic eye exam. And preseptal cellulitis, an infection of the eyelid, is a fairly benign entity. An orbital cellulitis can kill you. It differs from preseptal locally and systemically. Orbital cellulitis will affect the vitals of the eye. Acuity will be down. Their pupil might have an afferent defect. They'll have a motility problem. They'll have proptosis. And if you have the luxury of imaging them, you'll see fat stranding in the orbit, sometimes abscess formation, sinusitis, and then we look for this dilated ophthalmic vein, because the next thing after the orbit is the cavernous sinus. And you don't want to miss orbital cellulitis going into your cavernous sinus. That can be a lethal entity. Let's get into the trauma now. We've done some red eyes, and now we can get into this prison population and other things like that. I was surprised. I didn't see one of those shanks in the eye, but I know that Dr. Tubbs has seen that. Here's our friend fluorescein dye, again, reminding you that's what stains naked basement membranes. So if you've scratched your corneal epithelium off, you get a big staining defect in your cornea. These will heal in 24 to 48 hours with or without a patch. The corneal epithelium can replicate and mobilize itself quickly. And this is probably one of the only ocular emergencies or trauma situations that we give short-term adequate pain relief for. These things can really hurt. And we usually cover them with topical ointments like bacitracin or erythromycin. And if they're doing okay the next day, they don't need to come in and get checked. If they still have pain and foreign body sensation, we like to watch these heal or confirm that they have healed. It's an abrasion from an angry girlfriend throwing the tube of toothpaste. This is a mark of the striations in the cap of the tube. Every abrasion tells a story, doesn't it? Here's the little metallic foreign body, the little thing that's going to become a rust ring stuck to the surface of the cornea. It's amazing how hard these can stick. They can be drilled off at the slit lamp. I like to bend a TB syringe into a little hockey stick with the inside of a jeweler's forceps, and with numbing drops lift these things out of there and then treat them as an abrasion, so they can be fun. They can be fun to interact with, and they heal quickly. Oh, here's that big red font again. Must be something trouble. Beware. Hammering. The history of hammering or striking metal on metal. When you're faced with an eye, question about that. This patient just got themselves either a dilated eye exam by an eye care professional or CT, a fine-cut CT scan through the eye in the orbit. This is one ocular emergency that can leave the vital signs of the eye relatively intact. Little metallic shreds from something like this. They're much bigger than that rust ring. They go at supersonic speeds. They'll go right through your cornea or sclera without much pain, if at all. Sometimes you can't even see the entry site. They go right into the back of the eye where they rust and poison and kill the retina with metal ions, if not infection. So anytime you're faced with something with this history, it's hammering and striking with metallic objects, call for help. Don't take the fall on that. Here's one from pipe wrench, hammering on conduit in a home reconstruction project. There it is in the back of the eye, down where your ophthalmoscope's never going to see it. Visual acuity's okay, but it's going to kill the eye. Here's where it came off the wrench. We were that compulsive to fit those back together so it all makes sense. Here's another word I hate to hear in a trauma setting, BB. 11-year-old girl playing with a cousin, peekaboo with a BB gun. Into the ER we go. Here's the entry wound. Visual acuity on presentation, light perception only. No sense of direction, no counting fingers. Obvious entry wound. At that point we go to the OR. Here's the imaging studies. The BB goes right through the eye, through the front, through the back, clobbers the optic nerve at the orbital apex, so not only does it destroy your eye with the shock wave that imparts, an eyeball is sort of an underwater environment, and a BB's like a depth charge. The eyeball hates delivered kinetic energy, both direct and indirect, in the form of shock waves. And here's her disrupted globe with hemorrhage in it. These are eyes that are removed because they're painful and they become disfigured, and they pose actually an autoimmune risk to the fellow eye. Here's her, we gave her every chance. Here's her entry site repaired, even repaired the exit wound, worked back and sewed that, but the inside of the eye is one big necrotic blood clot, and she got a prosthetic and is doing well. Here's a fella taking down an old barn to recycle the wood, pulling nails out. One hits him in the eye. He gets a cheek full of fluid, and then his vision's blurry. Visual acuity obviously very poor. Pupil not reacting real well. He's lacerated his cornea from 12 o'clock to 6 o'clock. There's iris pigment stuck in that wound, so it sort of stains it. He's hit his lens, so he's growing a cataract. So here's an open globe injury, sort of the best sort. He's messed up the front of his eye, but his retina's okay. The cornea can be fixed. His lens can be replaced. This guy's kicked in a bar fight when he's down. I'm surprised we didn't see this in the inmate population. His cornea is fine, but due to increased pressure, he's bursted his sclera and got a posterior injury with loss of intraocular contents, and his prognosis is going to be terrible. Can't put that back together. So open globe injuries have, again, this wide spectrum of things which might do okay and might not. Anterior injuries, better. Sharp injuries, better than blunt. Better to be stuck by a knife than kicked by a boot. How much energy is delivered during the injury certainly matters, and their vision when they walk in the door. But again, for purposes of your evaluation, an open globe, protect them, don't feed them, elevate the bed, control nausea, and they're headed for the operating room. A couple of photos just for your viewing enjoyment. A hyphema, layered blood in the anterior chamber, much different entity than that subconjunctival hemorrhage that someone woke up with. This means something in the eye is broken. We don't know what it is. It's a relative ophthalmic emergency. They're going to need short-term and long-term follow-up. Here again, there's a larger hyphema layering out above the pupil. Retinal swelling and edema from a sudden impact deceleration injury associated with an airbag. Airbags hit you at the speed of Mike Tyson's fist, and little 98-pound females get really walloped by these things, and you can have a posterior segment injury. So if you've got airbag or car accident victims complaining of poor acuity, you might want to listen to that. Here's someone also hit by a fist, and they've got a large retinal tear here to your right, big jagged retinal tear, leaking fluid underneath, hemorrhage in the eye, so they're going to get a traumatic retinal detachment without further therapy. And here's another blunt trauma patient, actually two of them. This guy on top is looking straight at you. His eye looks a little smaller than the other eye. This guy on the bottom is trying to look up, and the injured eye doesn't. Well, what's he got? He's got his blowout fracture. We like to, again, the vital signs of the eye with blowout fractures, key physical finding. Afferent pupil defect, important to know from the get-go. You want to do the swinging flashlight test on these trauma patients. We prefer coronal view CTs. Here's the orbital floor broken, blown out, blood and fat down in the sinuses. Here's a medial wall fracture without any entrapment. A lot of isolated blowout fractures actually can be left alone. Surgery can be delayed or sometimes not necessary altogether. So when faced with these, of course, the globe takes precedent. Look for a globe injury and or visual loss. Coronal CT, best imaging modality. No surgery, especially no surgery right away, unless we've got persistent diplopia or significant enophthalmos. And surgery is often delayed. The exception is there's a variety of these with intractable nausea and vomiting from a trapdoor phenomenon that require surgery right away for relief. Finally, the optic nerve at the back of the orbit is susceptible to fractures, trauma, impacts. Called traumatic optic neuropathy, causes severe visual loss, but it so often happens in a dirty setting. Someone with compound facial injuries, maybe a brain injury, might be intubated, might be combative. They're not going to read an eye chart for you. They're not going to do visual fields. How are we going to know if their visual system got impacted? Swinging light test. Any case where the optic nerve has been injured or affected by trauma will give you an afferent pupil defect. So it's way up there with the vital signs of the eye. Finally, lid lacerations. The eyelid has a skeleton to it. The supporting structure is the tarsal plate, best seen as this little yellow thing here that we repair with high magnification and dissolvable stitches. We've got to get it back together just perfectly. Any rotation or vertical error causes a notch in the eyelid that will run tears constantly and requires revision. So full thickness lid lacerations you don't want to be sewing up on your own in the emergency room. That's cause for concern. And another variant is a lid laceration that's placed medially that goes full thickness because it's going to avulse the nasolacrimal outflow system. It's going to tear this canaliculus, and the repair of that involves some type of stenting procedure. We put little silicone tubes in there, leave them in 3 to 6 months before we remove them so that someone doesn't have a late epiphora, which otherwise is a very significant functional problem. And sort of in a case by itself. Here's an eye condition with no pain, no redness, no visual loss, no nothing, but I want to cover the sudden onset. That's the key word is sudden. This is a sudden onset or change in flashes and floaters. What happens is your vitreous jelly, it normally separates from the retina between ages of 50 and 70. When it does that, you'll see floaters, and it might pull on the retina and cause flashes. But what we're looking for is traction that might tear the peripheral retina. The retina tears very easily in some of these people. And a retinal tear will lead to a retinal detachment. The symptoms are identical. So someone in this age range with a sudden onset, not a gradual progression or that they're complained about them for 15 years, but something sudden, gets a dilated eye exam by an eye care professional within 24 to 48 hours because the impact on your life of having a real retinal detachment is extreme. The surgery is a fairly complex undertaking with a long recovery period, an unknown prognosis, and a long period of disability. Here's a retinal tear under great magnification. These happen way out on the side of the eye. Allows the retina to start separating from the choroid because the suction is broken. When we find a retinal tear, we hit it with an argon laser. Easy to do, works every time, glues this down, stops the detachment from developing. So this is one urgent or emergent situation where recognition and referral can make a huge difference. A lot of flashes and floaters don't have a tear, but you can't tell looking in who has that. We're out of time. This is the non-urgent chapter, and I'd be happy to cover this on a one-on-one or group basis at the end of today or tomorrow or the next day. I'll be around for the whole thing. People always have a number of other eye questions. I want you to get your money's worth and be fulfilled in ophthalmology. Thank you very much for having me today. Oh, a couple other, there's always a question. Let me point you want a good book? This is not a plug. I have the Will's Eye Manual. It's actually for sale out here. It has everything you want to know. It's just written by the Will's Eye residents in Philadelphia, a long legacy of this. Covers everything you could need in an urgent situation. Another resource for educational materials if you need, the American Academy of Ophthalmology, AAO.org. Puts out a very nice little syllabus of eye issues for emergency room and general medical physicians. A lot of good pictures in there, a lot of coverage on a good level.
I want you to answer a question or two, but
okay.
But sometimes a rep or a patient will say, Dr. Lair, you're awesome, and I always say, no, I'm merely very good. But this was awesome. So.
Thank you. Pleasure. Question. Got 2 minutes for questions? I see.
Yes. We talked about BBs. What about airsoft guns? Have you had any?
Have not had eye issues with airsoft guns. The whole key to that aspect of ocular trauma is how much energy was delivered to the eye. A BB has an incredible amount of kinetic energy and a big shock wave around it when it gets into the underwater environment. Pellet guns, everything is just as bad. Sure. The other bad thing we see is paintball guns, paintball injuries. Oh, that's okay. Yeah, they won't burn you. Every ophthalmologist spends hours looking into those things because we're just that way, and it hasn't messed me up yet. No, yeah. It takes a lot. The settings of those versus what we use when we laser things, and we'll do this with diabetes if we have time, is, yes, in the front.
Question, like we don't have slit lamps in our office, but we have fluorescein dye. Can you see dendrites with a fluorescein dye, or do you have to have slit lamps?
You could see dendrites with it. If, for someone like me who's nice and presbyopic, I'm going to need my reading glasses or my loupes. But that's one thing you can see.
That would be an indication to send them out.
Sure, dye uptake, and also what'll uptake dye is mucus in the eye. It moves around. Everyone sees sort of dye uptake. When dye's uptake from an epithelial defect, the margins at first are very crisp and clear, and they won't move with a blink. Fluorescein stains it like that, and if you look 10 minutes later, it's sort of diffused around and become more of a cloud. So put it in, look right away. Okay, next. Thank you. That worked good. We can get it after the next one because I'm going to listen to this.
What a great day. Thank you all for your attendance.